Right, as if by magic, on your tables you will have discovered some paperwork has appeared during coffee. That's key to what's going to happen now. My name's Richard Curry. I'm from SEHTA, like David Parry. He's explained what we do. Our remit is to create sustainable new businesses in the health and social care sector. So this opportunity for us is extremely important. The whole opportunity presented here of creating new and innovative services and service delivery models requires the involvement of industry from the beginning. And so it's really a very exciting opportunity. Right, so it's your turn now. You heard this afternoon before coffee on what I call 3 good practices from around Europe, 3 that have been identified through the CASA project. With a group as big as this, we struggled to find a way of gathering your input on the messages that you heard and garnering your comments. So what we've decided to do is an online survey. So when you get home tonight, you will find in your inbox a survey tool, which we'd be very grateful if you'd complete and send back to us. What we're going to do now, though, is just for the next hour or so, is a general discussion on that survey tool. And as I said, that survey tool has appeared on your table in front of you. So how we're going to do that is for the next 20 minutes till 15:15, if you could work in your tables, or if you feel you haven't got enough people, commandeer a few people from other tables where there aren't too many people sitting. If you could work on your tables to complete the questionnaire. The questionnaire sort of says things like, what further information do you need on the good practices? And then it starts going through questions about how could this be implemented? What sort of things do we need? What is the need? What is the organizational structure? What is the technology? Is there anything that you know of that could be used to meet this need, etc., etc. So a lot of questions in there, probably some of them quite complicated, and what we're going to do is discuss them. So if you could start working in your tables for the next 20 minutes on the questions, and then we'll have a facilitated discussion afterwards. Thanks very much. David's got a question already. It shows you how clear the survey is.
We haven't done that, have we?
No.
Why don't we do the care home in Belgium?
Sorry. He's pointed out that unfortunately we've given you version 1 of the questionnaire, which we did previously have a representative from Andalusia coming, but now that's changed. Obviously, the first good practice that was mentioned was for us for the Belgian care homes. So if you could strike out Flanders, if you could insert Flanders as the first one, I'd be grateful. Thank you very much. Okay, so that's taken another minute of your time as I explained that. So if you could start working on those together, that would be great. Right, thanks very much indeed. So you've had a sort of a first go at the survey. Any questions that have arisen because you've tried the survey that you'd like to ask any of the presenters? Oh look, it is Flanders. Magic, isn't it? Anybody like to, any questions that anybody wants to ask of Ronald? Yes, sir. Oh, good. Oh, there's a microphone coming.
There's a microphone, right, thank you. We have because we're linking Kent County Council and public services against this, there's a few questions about what level of patients were in that particular home. What was the driver to be so good, particularly when a lot of care homes are privately owned here, so therefore changing what they do inside the care home is not under the control necessarily of Kent County Council. So what was the driver there to be so good? Was it because you got more patients and increased business, or what? And what was the cost per patient?
Thank you. Ronald, did you catch that? Yeah, quick.
Okay, thanks. To start is the question about the costs. Staying in the Weverbos does cost €130 a day a resident. And from that, residents pay €57. The rest is paid by federal government. The average level of the day price people pay in Belgium is around €50. This compared with the other nursing homes, we're a bit expensive, but compared with completely new nursing homes, it's nearly the opposite. New nursing homes are starting nowadays around €65 a day that residents should pay. The people in Weverbos on the ground floor and the first floor, what is part of the nursing homes, are 100% dependent elderly. The second floor is service apartments, and that are people who are not dependent. But that's another financing system. And why are we doing that? It's just because we feel that way. Yeah. Yeah, when we are here on Earth, we can as much do something good for other people, and yeah, that's it. And the baseline of our organization is proud on 80. Yeah. And if there's some time, I've brought a small movie about that, but we'll see.
Okay, thanks very much indeed, Ronald. Okay, right, now it's your turn. Suppose, yes, sorry, Anne?
Are there further questions?
Oh, sorry. Yes, I am a bit hasty, aren't I? Does any, yes, go ahead.
Yeah, I have another question for you. It's about have you noticed any impact on your A&E attendances and admissions into hospital of your patient cohort in comparison to patients from other nursing homes or care homes?
We don't keep statistics about that, so I can't say that. But one of my demands, I told her we have also a geriatrician as an expert working for us, and that's one of the questions I ask her from. Make sure that our residents have to go less to a hospital than other nursing homes. But it's still a long way to work about it. Something I have seen that Weverbos now exists for 2 years. The first year, we got 3 demands of euthanasia. That's legal in Belgium. And some months ago, I wondered, every demand for that has to be reported to me because it has a big impact. And there were no demands last year. Is it because the way we're working? I don't know, but I'm wondering about that.
Yes, Anne.
I also have a question for Ronald. Could you say a bit more about how you organize meals and the philosophy behind that?
As I told, all meals we serve are diet meals. So no sugar, no salt, etc. But we add spices to make them, to give the smell, the taste back to our residents. We want our residents to keep contact with the others. That's a part of maintaining the self-respect. When you meet other people, you talk to them, they ask you questions, etc. We call that our social model, and that's why we encourage them to take the meals together and even add a price on it. When our residents have the opportunity to sit together for the meals, and they want to have a meal in their room, it's possible, but they have to pay €2.50 a meal for room service. Not when they are ill and must stay in their bed, but when they can come together, well, they must pay. In the whole house, 100 residents, it's only one person who pays for that. So our goal is achieved, and people even can say, oh, I save €7.50 a day by eating together. But in going, when walking around for the meals, etc., they get tired. They got practice. We don't need a lot of therapists. And also, when they're sitting together for the meals, of course, it's often discussion, oh, you're sitting on my place, etc. But that's good that happens in society. One other aspect of meals is our mobile kitchen that brings the smells of preparing food again to our residents. 80% of our residents were housewives. So why shouldn't we allow them to cook?
Excellent, thank you.
Thank you. Thank you, Ronald. Okay.
Other questions?
Any more questions of Ronald?
No, and other presenters.
Sorry, we're going to go through this one first,
Okay.
and then we're going to go on to the others. Okay? So in the interest of time, we'll just pick a couple of these issues. I think the question is, what is the key feature that is to be transferred? What is the key issue that needs to be transferred from Flanders, from the care homes there, into the Kentish care homes that would make this work? What is it about this? Ryan, could I ask that table there, what was your answer to that question? What's the key?
What's the key point? What's the main driver for this project? Quality, we felt.
Quality.
Yeah.
Quality of?
Care.
So I think Ronald mentioned the whole thing was individual-centred, patient-centric, person-centric. So that's the key issue. Anyone else with any ideas, David?
I think we were impressed by the technology, and I think we were particularly impressed that the technology seemed to empower both the residents and the staff, and also produced efficiencies, so allowed the staff to have more time with that one-to-one interaction. And that's an interesting dynamic, I think.
So it was improvement in the time that staff had.
Yeah.
Because we were using technology appropriately.
Yeah.
Anyone else with a view, one key message, one key important issue that was transferred or needs to be transferred? Yes.
I think it's about the value system, because what led to the technology transformation with technology was the value system that you developed. You wanted better quality care for older people in care homes. And that is, I think, one message that should be transferred to Kent, is that we want better quality care for our patients. It's that value system that all of the workforce in Kent should be embracing.
So better quality care all the workforce should be embracing the same objective, the same goal, and it should be set quite high. Right. Okay. So, if we now pick just, say, another issue. One more?
Just building on what you've just said, it's also about making sure that the technology is integral to the care and support pathway for the person. It's not an add-on, but that it's more seamless in the way that people are supported and the person's journey and their care within the home.
So it's appropriate use of the technology, not for the technology's sake, but when it makes an actual difference to the level of care, the efficiency, the effectiveness. Great. Yes?
I, having just talked with Ronald a little bit earlier, and Class as well, what Class spoke about was this is a living model, not a storage model. And I thought that was a really good, an analogy really, and that's what we should be looking at in Kent, a living model, not a storage model. But also, the discussion I had was that there are a lot of small changes that can be made at very little cost to make a real difference to people's lives. And I think some of that was just explained in terms of the eating, how they, but also things like painting, the walls and the whole environment. Actually, small changes could make a big difference.
Small changes, and it's a living model. So people are supported to live there, not just to exist, not to work. They're not put there because that's kind of the end of the road. They're put there because this is some place they will thrive. So if you have thrive, if thrive is your goal, then it changes the whole thing completely. Good. Okay. Yes, ma'am.
Yes, hi. I think the very first slide really set the tone for the model in terms of the structure of the organisation, and I think the ethos of the organisation is much more sort of person-centred, because you've got the customer and the support staff in the middle, and the knowledge and the other support are supporting the customer and the support staff. Whereas I think in this country we're more inclined to have a top-down model, where the support staff and the customer are at the bottom, and they're there to really support the people at the top. So I think in order to start to really, change how we see older people supported, means, I think, a radical rethink of how we look at supporting the support staff who support those people.
So the level of support we give the support staff is actually key to them feeling empowered and fulfilled in their job. Right. Okay, in the interests of time, we'll move on to the presentation from Alistair. So same question. Any questions to Alistair about his presentation and about the model that they're developing in Scotland and the way they're moving forward? If I could then ask that table there. Yes, if you could give the mic to that gentleman. What did you think about the Scottish initiative?
Well, we talked quite a lot about integration on our table. So we thought the ways of working together, especially around the kind of teleconferencing stuff, was really quite interesting. And I suppose just thinking about it now, probably one of the things which we thought would be one of the biggest issues is how to get the kind of the consultants talking with the patients and getting them working that way.
Well, I wouldn't exactly say we've cracked that by any stretch of imagination. Certainly, our sort of rural and remote communities, it's been much easier. The Highlands and Islands have very much led the way through necessity more than anything else. Orkney and Shetland being a couple of really prime examples where not only is it logistically challenging to transport people from the islands into the mainland, it also costs a hell of a lot of money. So, just from that perspective alone, the consultants very much see the benefits of it. But one of the things we are trying to highlight is the fact that people on an island can be just as isolated and just as in need as somebody living on the top of a high-rise flat in the middle of Glasgow. But then the challenge as well is, although the infrastructure that we necessarily have in the Highlands and Islands isn't always top-notch, just because commercially it's not necessarily always viable to install fibre optic cables. In Glasgow, less than 50% of the population have access to internet, because a huge amount of it is social housing, and the social housing organisations haven't installed internet into the flats either because it's expensive. So it's one of the reasons why, in terms of consultant to patient thing, I think we're still very much at the beginning of that journey. And one of the things that we're actually looking at is things like familiar devices and going through digital television, which is why I think Luke and Local are here as well today. Our project around Living It Up is very much around how we utilise those devices that people already have in their own homes to be able to access health and social care services.
Just a question, which is, what's the percentage? Hold on, Nick. Microphone.
A brief question. What's the percentage of people in the social housing who have mobile phones, specifically smartphones?
I couldn't tell you specifically about smartphones, but I do know that in terms of smartphone utilisation across Scotland, it is increasingly higher. There's a recent project in NHS Grampian, which is the northeast of Scotland, where I was saying earlier, I can't actually remember exactly what condition it is, but it's slightly younger people, and they wanted to use apps to help people manage their own condition. And of the 100 patients they put on that service, 97 of them had a smartphone already. So it is increasingly becoming bog standard. It's not everybody, but it is increasingly becoming bog standard.
Yes, sir.
Thanks. I note in Scotland there is a push from the centre to have integrated health and social care budgets and integrated care organisations, whereas that doesn't necessarily apply, let's say, south of the border. It tends to be left to individual organisations. How much do you think that, because of the central drive towards the goal that we all really aspire to achieve, that you've done a bit better than we have done locally?
I think there's no doubt that we benefit that we're significantly smaller. And also, we've been working towards integration for probably the best part of 10 years through various things about partnership working, but it's always been voluntary. There's always been the legal basis for areas to formally integrate. NHS Highland and Highland Council are the only ones who've actually taken that step. They integrate all their adult services moved into NHS, and all their children's services moved into the council. So they're the only ones that have taken that formal step. But prior to the last Scottish elections, actually every single party had a manifesto commitment to integrate health and social care. So we've had the political consensus in Scotland that I think is now increasingly beginning to exist at a UK level, but it hasn't necessarily always been there. So we've been quite lucky in that sense that we have actually had that kind of historical political consensus. And the consensus exists in local government as well. They don't necessarily agree the best way to do it, but the concept is fairly universally recognised.
Any more? Okay. Right. Moving on then. One thing that does interest me, and I'm sure it interests everybody here, would you like to make some comments about the industry's contribution to the achievements in Scotland? Yeah. Give him a minute to think about it.
It works in two ways, actually. Some of the bigger companies are perhaps less keen to engage with us because we're such a small market, but at the same time, because we are such a small market, it's easier for some of the companies to see us as kind of testbed area. So they're much more interested in getting involved. A couple of examples are, we've got Samsung, we've got Philips, we've got Microsoft all coming in to actually engage with us at a Scotland-wide level because we're able to operate on that kind of pan-national basis. They're actually able to see how their equipment or their technology or their approaches to care might actually benefit on a slightly larger scale. But again, it's a relatively new approach for us as well, actually engaging industry from the very beginning. But in the last sort of, I would say, 18 months or so, it is becoming increasingly common for us to actively try and encourage innovation between health and industry as well.
Thank you. Anybody with any comments on industry, NHS collaboration in this new sort of integrated health area? Question 3. Yes, madam.
Hi, it's just more of a comment really about how we haven't got a choice but to use industry and to work with industry. But my caveat to that would be that it has to be a mature and open relationship. And that when we talk about shared risk, shared reward, we have to make sure that it's not industry taking all the risk and us taking all the reward. And it's about that adult relationship that helps us to move forward and bring that innovation and these new ways of working into reality.
Any more comments on that point? Yes.
I suppose my question would be how health and social care service providers, the independent sector, actually work in partnership in Scotland to actually deliver innovation.
Continue the merry-go-round with the microphone. I mentioned in my presentation about our change fund, which, as we're saying, health and social care partnerships had to work in cooperation with the independent sector and the third sector to actually access that. And that was the first time, I think, we really had a large-scale drive to fully engage the independent sector in the design of services. It wasn't without its challenges. It's a fairly disparate grouping of people. You had the challenge of trying to identify an individual within a given area who could represent other independent care providers who, at the end of the day, were rival businesses. And they had to come to the table and see how they could design the sector, redesign the sector as a whole in a way that wasn't necessarily particularly favouring their own business. So we certainly had those challenges. It probably took us the best part of a year to overcome some of those challenges, but we had quite a strong ally in Scottish Care, who are the umbrella body for independent sector providers within Scotland, who are fully bought up to this from the very beginning. We engaged with them right from the start, and through them we now have development workers, independent sector development workers employed by most health and social care partnerships in Scotland, looking specifically at what the contribution will be of the independent sector going forward.
Thank you. Any more?
I'll keep this just.
Okay, thanks very much indeed,
Okay.
Alistair. That was great. Okay, moving on to any questions of Ignazi, and very different sort of presentation about shared records. I'm sure they were implied in the other two presentations, but he actually mentioned it. So, any questions to Ignazi? Yes, sir.
How long did it take for the various organisations to agree to share records? And presumably you must have got consent from all of the patients within Catalonia to agree to it as well.
Okay, so here, sorry, down there. Well, in fact, it did not take any long for patients to, because we did not really ask for consent. Because, in fact, clinical information is owned by the patients. So, therefore, if you want to share clinical information with the patient, if you are accessing this, it's because you are willing to access clinical information. The other thing was about clinicians. And the point here is that is exactly with the same legal framework that normal clinical services are provided, because you only allow access to the clinical record when you're having a consultation with that specific patient. So, for example, a doctor cannot access any clinical record that he does not have an appointed meeting with the patient. And apart from that, also there are full records of who is accessing every single piece of clinical information for a specific patient. And in fact, this is one of the issues that we're also allowing the patient to see. So who is accessing my files?
Okay, any further questions to Ignacy? Yes, lady over there. Thank you.
Who's actually hosting the platform that all the information's held on?
The Department of Health. So the regional government is the one who is having all the infrastructure being provided. And this is something that as a public authority, we just decided that we have to provide some kind of basic infrastructure to allow this kind of information for both for clinical issues, but also for allowing the patients to access their own clinical information. And it was much easier that if we did already have this shared medical record to enhance the follow-up of clinical conditions for professionals, to just offer this clinical information to the patients. And we know that is kind of a starting point, but we did want to provide this kind of infrastructure, and what we did after is defining the interoperability conditions, the rules, framework that any kind of third-party application can use to be connected to the personal health channel of a patient, so that patients can choose which kind of third-party applications they want to use.
Yes, sir. Yes. Quick.
Could I inquire, have you had any data breaches?
I don't think so. No, in fact, so I think that the possible data breaches are, I think, lower than with paper. So that, because within a hospital, all the professionals need some kind of identification to access to their clinical workstation, and from that specific clinical workstation, then they access the shared medical record. So they are previously authenticated at their own premises, and then we know who is accessing that. And at the level of patient access, we're just using, I think that higher standards than banking solutions. So we're using digital identification, that we only allow digital certificates both in ID cards or digital software certificates.
So patients will have access to a certain level of information And they will also know who is accessing their records.
Yes.
Okay. Yes. Quick.
Is there any concern about allowing patients to have their records, for example, if they are mentally fit enough to be responsible for them?
Yes, sure. Mental illnesses are one of the main concerns when you allow access to this kind of clinical information. But I think that what we are sharing right now is, for example, mental health care providers. They are not publishing the reports on the mental condition of a patient. What we are sharing are mainly health conditions for GP, for acute hospitals, and these kind of conditions. But we are doing this kind of review on which kind of information should be shared with the patient. And also, we have this issue right now also because we're starting the process to also include all the social information about a patient. So all the social information about the user is something which is written by a professional for a professional use. So how do you allow this kind of information to be shared with a user, in fact? So this, there are lots of legal and ethical issues that are going to really be tackled in every single issue at a time, because also for children who is allowed to access the children health records, parents, until which age. So I think that we allow access for the patient health record to all the citizens who are above 16. We do not allow access for all the other citizens who are below.
One last question over there, yes.
Sorry, another data question. Is there anybody overseeing the access to the patient's records other than obviously the patient themselves?
Sorry, I did not got the last part.
Obviously the patients themselves can see who's accessed their records, but is there anybody, like for example your Department of Health, is there anybody overseeing it to see if there has been any breaches?
I really don't know this kind of really technical part, but I think that it's the same possibility, like you have to be authenticated in a certain way so that a specific professional has accessed your information, but there is no kind of, I don't think that there is a kind of proactively seeking of all the professionals who are looking to clinical files that may not be allowed. I think that the main issue is that a clinician is only allowed to access that clinical record if they are having a consultation, an appointed consultation. And if not, they have to ask for permission, for example, in the condition that they are having a kind of telephone consultation, they have to allow for permission, and then the system allows it. But they have to do it proactively.
Okay, thanks very much indeed, everyone. Look, I think information sharing is absolutely fundamental to shared care, and we could go on debating this for a long, long time and getting the details of it, and it would be very interesting. But in the interest of time, if I could ask Robert just to sum up the discussion and the day. Thanks very much indeed.
Thank you. Well, to sum up, it's been a very interesting afternoon. It seems to me that care and quality is key, and that we can definitely aim high. It's not necessarily a thing that's very expensive to aim high, but that's where we ought to be going to. Interoperability and information governance, as Richard said, is always something that's always highlighted. And sharing of information is key for us if we're going to upscale and if we're really going to use this information. Quite often, though, I think we sometimes hide behind information governance. Actually, the sharing of information should be a key priority. So actually, we've got to work this out. And I think that that's one of the things that we'll be taking forward as one of the key actions. I think we really need to move to this supported self-care model whereby the person is much more in control of their information, as Ignacy says, and that we should really be looking to making this much more patient and citizen-centered, where they own the information. And I also think there was messages put out that we should be going to the market to get them to be not the problem, but actually the solution to some of these issues, and we'd be better to try and ask them for those questions so that they can come out with the solutions according to the outcomes that we would like to see put in place. Thought we had a really interesting component about where innovation is really key, and that we really need to move to a culture change and stop talking about it and start doing it, and that really this is all around the people creating and implementing ideas that add values. So in conclusion, one of the reasons for us being here today is because of CASA and our will and wish to continue this sharing of information. And actually, we've shown that with the examples that were shown today, both in Scotland and Catalonia and also in Ghent, that we are probably much stronger to solve these problems together, and that we could actually use the resources of the EU to try and make sure that we implement this, and as well as linking this to research and those links with industry. So later on, today we're going to be launching the Kent Innovation Pioneer Hub. And that's a focus that can bring together some of the issues that have been talked about today, but how that we, as Kent, we have a focus of innovation and we start to be recognized as a Kent focus for innovation. And it's all the people in this room and also people who are on the front line who are the people who can contribute to that innovation. We are very much wanting to link this to the Academic Health Science Network in terms of some of the structures of the NHS, but also other networks across the UK. And one of the fundamental things that we are going to be doing is working with our EU partners to see whether we can have a series of these hubs across our regional partners, and that we will be trying to put together a bid that allows us to get some resources out of the EU to do that. I think it's very important to say that innovation, and the hub in particular, is not there to be in competition with anybody. It's actually there to try and coordinate and bring the areas that are going on already. And as Klaas told us about it, this is about a culture, and we know that innovation goes on at all sorts of different levels. So it is a question of how can we use the innovation hub, but also the integration pioneer to barrier bust some of those things that are stopping us get to the place we want to, whether it's around quality or information or use of technology. So I'd like to draw the meeting to a close. I think the speakers have really given us a different insight into what can be done outside of Kent. I know that there are quite a few of these initiatives already on in Kent, but somehow we need to move this to be much more upscaled and at much greater pace and scale to try and meet the present challenges of the NHS and social care, and how we increase the number of people who are contributing to this. So the idea out of this innovation hub will be that we will have a concentrated view of what some of the challenges, and we'll be trying to work with the people who are engaged in the Integration Pioneer Group to see how we can also then include people at all the different levels, and in particular the people who are delivering services, care home staff, clinicians, managers, so that all together we try and create this culture of people working together to implement ideas that add value. I love that statement. But it isn't to stop the need for a lot of this implementation to go on at a local level. So it needs to link to the local initiatives that are going on. So I'd like you to congratulate the speakers on their talk today. So I'd just be grateful if you could just give a round of applause. And I'm particularly grateful to all of them because they've made a lot of effort to come here today. They've travelled a long way. And I think it's been great for us to have that access. And then I'd also like to thank the people who've made today a success. So I'd like to congratulate Francesca Venato, Sarah Collins, and Claire Ansell from SEHTA. So again, can we give them a round of applause?